Okay, we're just going to do one final test. York, can you hear us? Yay! Great, fantastic. Can you see the slides? Wherever if you can see the slides. Yeah, brilliant. Okay, good morning everyone. Sorry for the hitches. Hope we got it sorted out now. Welcome to our Medical Emergencies course. We didn't really know what to call this course, so we know that we've got an exam coming up. It's sort of about clinical management, diagnosis, management patients, that kind of thing. So we're going to focus quite a lot on that. It's not just going to be sort of what to do in emergencies and stuff like that, but the things kind of cross. So just a little introduction. My name is Ed Wallet. I am a GP trainee in central London at St Mary's Hospital in Paddington, currently doing sexual health for my sins. I set up Podmedics in 2007 and have been sort of running the company since and producing quite a lot of the podcasts and sort of generating new people to do podcasts and things like that. And I'm going to hand you over to Stevan now, who's going to do a mini biography.
Not much of a mini biography, but my name is Stevan Wing. Hello, and I work with Podmedics around the last year and a half. I'm a core medical trainee within London.
Enough said. Right. Just a quick disclaimer. Some of you will probably start to feel, or may start to feel a little bit queasy during our talk. My advice is keep your eyes fairly level. Have some breaks, look off to the side. We use quite a lot of rotation and movement, and some of the feedback we've had before is that it tends to make people a little bit queasy. But hopefully you'll see the benefits of the kind of presentation software that we use. It's kind of quite helpful in understanding the big picture rather than just moving from slide to slide to slide like you always do with PowerPoint.
It's no IMAX though. It's no IMAX.
No 3D glasses today. Okay, so Podmedics, we're just going to do a quick introduction of what Podmedics is, just to give you a bit of a background about what we are, what we do, and why we're going to be talking about some of the things in the way that we do today. So, as I said, Podmedics set up in 2007. What we do is we provide quality educational materials to undergraduates. Now, I set up the company basically because I realised that, certainly in Imperial, where I was a medical student, students tend to get just thrown into the hospital when they start their clinical attachments with no real sort of foundation on what to expect, what the common conditions are, how the hospital works, that kind of thing. So I set up Podmedics with the aim of doing very short video and audio lectures that give students who are just starting out in hospital a sort of foundation on which to build their learning when they see patients, when they examine patients, and when they learn from doctors in the hospital. And subsequently that's has moved on a bit more, and we now sort of look at teaching materials for students throughout their education, right from the beginning, right the way up to the very end, towards finals. Mainly we produce things called podcasts, which are little sort of portable radio shows that you can download from iTunes. iTunes is very big for us. We have quite a large presence on the medical section of iTunes. And we also have a website where we provide a lot of materials as well. And in fact, we've just launched a brand new website, or it's going to be launched officially tomorrow. So do head over to podmedics.com and check it out if you're interested. We're not going to talk a lot about that today because I hate plugs. Oh yeah, and this is when you can listen to podcasts. Some of the feedback I've had is that my voice is very good for falling asleep to. So hopefully there won't be a problem today, but if any of you suffer from insomnia or have addictions to Zopiclone or anything like that, you may wish to consider it as an alternative sleep agent. Does it work? We think so. This is a snapshot taken a couple of days ago from the top medical podcasts on iTunes, and apart from the bottom one, I think we've got every spot. So obviously people enjoy what we do, and hopefully you will today. So what are we going to do today? We're going to tell you medicine, but this is not going to be like a sort of typical lecture that you're probably used to, because we just haven't got time to do that. We can't teach you everything that you need to know about medicine. What we can do, however, is look at how to structure your thinking when you're learning yourself. What we can also do is look at some common systems that are really, really useful, that enable you to structure your learning and your knowledge of various conditions. We're going to look a little bit at some techniques of consolidation and how you can, during your revision, avoid repetition by using some of the structures that we're going to try and teach you today with some practical examples. So, what systems are there? This is probably, if I was to select one sort of section, it's probably a bit selfish of me to do this with Steven standing here, but if I was to select one section of today, it would probably be this that you should take away. Forget all the medicine that we're going to teach you today. This is what you should be taking away. There are two systems, essentially, through which you can tackle a problem or a disease or a way that a patient presents. And these two systems are, you can either say, okay, I'm going to learn about the disease, or you can say, right, I want to take a more patient-centered approach. And I'll explain what those things are. The disease-centered way is just the sort of typical sort of structure that you would have in a book. The difficulty is that some books do things in different ways, some books structure things in different ways. So the key thing is get your own system for doing it. And this is the system that I think works very well. And certainly, even as a postgraduate now and as a doctor, if I'm learning about something new, this is the system that I use. I take an A4 side of paper and I write this scheme down the left-hand side of the page. And then when I'm reading, when I'm listening, when I'm doing whatever, I just fill out in the relevant section. So what are the sections? These are the sections, okay? So always start with a definition if you're learning about a disease. Always, always, always start with a decent definition that gives you an overview of what that disease is, okay? Then move on to epidemiology. Now, epidemiology does not need to be at your level. You don't need to know this is X percentage, Y percentage, incidence, prevalence, etc. That becomes important when you're a postgraduate. But you need to know simple things like, is this a common condition? Is this not a common condition? Is this a rare condition? That's the sort of stuff you need to know. Is it more prevalent in certain geographical areas? Because that's going to be important when you're answering questions in your EMQs or your SBAs or whatever. Then the pathophysiology. This is the most important bit. And what I always do with this is I draw myself a little flow diagram which sort of illustrates the pathology and the natural history of the condition. Because if you understand how a condition comes about and really understand the mechanism, the flow of that condition, the stuff that you learn about in terms of the way it presents is going to make a lot more sense. And if you try and relate the way that the condition comes about exactly to the way that it presents, you'll find your life a lot easier. Clinical features. So how does the patient present? And there are two aspects to this, and always divided up like this. You've got, I haven't done it here, but you've got your history and you've got your examination. And you should always subdivide your history into general things and specific things. Okay, so general things, for example, in a patient with a malignancy might be weight loss, loss of appetite, fatigue. While more specific things might be something to do with where the malignancy is come from. So maybe coughing up blood, hemoptysis, chest pain, or maybe a change in bowel habits and bleeding PR. Examination. We're not going to talk a lot about sort of examination techniques or anything like that today, because that's not really why you're here. But once again, always try and subdivide examination into the way that you would if you approached a patient, examine them. So you've got obviously inspection, palpation, percussion, auscultation, etc. Always try and divide things up into that section. When you're reading about the clinical findings in the book, fit that into this structure. Next, investigations. Okay, investigations. There are sort of a couple of approaches that you can take to investigations. If ever you're stuck for investigations, think UBEX. Okay, now this is brilliant. On a Monday morning, you're on the ward and you get asked, what are the investigations of blah, 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 and you really, you come up with the most extreme one first. You don't know what you're talking about. Think to yourself, UBEX. So how would you investigate this patient? I would do urine, blood, ECG, chest X-ray. Okay, you cannot really go wrong with those four things. No one is going to shoot you down for saying that pretty much ever. They might then go on to say, well, what blood tests would you do? Or what might you find on the ECG? But generally, that's a really good answer. And sorry, the special bit stands for special tests. So that's if you're really sort of a bit keener and you can think of some specialist tests for that condition that you've been asked about. But by far and away, the best when you're learning about a condition is to have a table of investigations. And this is one that we use a lot in all our podcasts. And it's basically, it divides up investigations into 5 different modalities. Okay? Cultures, bloods, imaging, scopic tests, so that's endoscopy, bronchoscopy, including biopsies, and functional tests. So if someone were to ask you, okay, how would you investigate a patient with pneumonia? If you didn't see that, you might sort of just go, blood tests, chest x-ray, but you're going to come out with a few things, but you're not going to get a complete list. But if you went through it with these main headings in your mind, when you were asked, you would come up with a lot more stuff. And you would realize why those tests were important. So if we start at how do you investigate a patient with pneumonia? Let's start with cultures. Okay, what might be a useful culture? I suppose a sputum culture might be a reasonable thing to do. If the patient had a fever, maybe blood cultures would be a reasonable thing to do. And generally, when patients are admitted to hospital, urine cultures is generally a good thing. And then you suddenly think, isn't there something in the urine that's relevant to pneumonia? Maybe sort of Legionella antigens and that kind of thing. So you suddenly start thinking about more things and get more things in your list. Done it, yeah. Then you move on to bloods. Okay, always divide bloods into arterial bloods and venous bloods in your mind. Okay, and go then think, okay, will I do an arterial blood gas? Well, yes, because a pneumonia may cause a change in the gas exchange within the lungs, and I might like to know if there's any acidosis going on. I might want to know the pH and if there's any respiratory failure. Venous bloods, well, we always do venous bloods. That's why it's the B of UBEX. What blood would I want to do? And you go through in the top and you say, okay, would I want to do a full blood count? Yeah, probably, because I want to know if the white cell count is raised in the pneumonia. Okay, maybe the patient is anemic and that's a contributing factor or a comorbidity. Would I want to do U's and E's? Well, absolutely. I want to know if the urea is high, if the patient is dehydrated, if they've got any signs of renal failure from sepsis. Okay, would I like to do inflammatory markers like a CRP? Yes, absolutely. This is an infective process. That would make sense. How about LFTs? Oh, yes, I remember that some types of pneumonia can cause alterations in LFTs. That would probably be a good idea as well. Okay, do you see what I'm doing? I'm going through the list, and I'm not regurgitating the 16 investigations you need to do for pneumonia. I'm sort of figuring them out from what I know from other conditions and what might be relevant. Imaging. So once again, start with the most simple plain x-rays. Okay, a chest x-rays, patient with pneumonia, yeah, that's going to be pretty obvious. Okay. But going down, if they have complications of pneumonia, if you see abscesses on the x-ray, you may want to think about doing a CT scan. Moving on to scopic and biopsy, well, here probably not. But you might think that in some pneumonias, for example, PCP, sometimes they like to do bronchial washings and things like that to make the diagnosis. So that could be a bronchoscopy might be relevant. And then finally, down to functional tests. Now, this is the one that needs a little bit of explanation. All that functional test means is that it's a test that's specific to a certain system. So for example, I would include an ECG as a functional cardiological test, spirometry as a functional respiratory test. Okay. So here one might imagine that maybe if there was any suspicion of chronic obstructive pulmonary disease, emphysema, anything like that, that a patient may go on later to have spirometry. Okay, so hopefully that just illustrates a little bit about how you can break down these investigations. The trick with this is to start using it and use it for every condition, because the more you use this structure, the quicker you'll get at figuring out what investigations you need to do. And then finally, and this is going to be a big focus on what we talk about today under the specific conditions, treatment. How do I structure treatment? Well, the first thing to say is whenever you're asked about how to treat a condition by anyone from this day forward, I want you to say, I would resuscitate the patient. Okay? If you say that, then you are safe. I mean, not like safe, but like you're safe to be a doctor. Okay? Because you know that your primary goal is to keep that patient alive, and the person who's assessing you realizes that as well. So you always say, I would resuscitate the patient with respect to the airway, breathing, and circulation. Now, I'll tell you a story. When I was doing my finals, I was asked by a very eminent renal physician at the Chelsea and Westminster Hospital how I would treat a patient who presented with an acute exacerbation of COPD. And there's a beautiful medical student, and listening to my own good advice, said, I would resuscitate the patient with respect to airway, breathing, and circulation. She rolled her eyes and goes, don't give me that crap. Just tell me how you want to treat the condition. Okay, so it won't always work. But at the end of the day, she knew that I was safe because I'd said that. Okay, and your consultants and the people who assess you will appreciate that because they know that they can trust you as a junior doctor to be safe. Okay. And I'll give you examples of how to use that A to E approach later. And then you can go on to say, well, if this patient was acutely unwell, I would want to do a few things before I started to think about definitive management. Okay? And the nice thing here is MOVE. Just like we had UBEX, we've now got MOVE. And MOVE stands for monitor, oxygen. Okay? Please remove from your mind any fears about giving patients oxygen. Okay? Especially there'll be some people sitting here today who think that patients with COPD can't have oxygen. They'll die. It's never unsafe to give someone oxygen. Okay, well, that's not entirely true, but generally it's okay to give someone oxygen as long as you're doing M, as long as you're monitoring them. Okay? V for simple venous blood tests. Okay, always a good idea. And E for ECG. Is that right? Yeah, sorry. Steven usually does this bit, so I'm just sort of checking. Now, moving on to definitive management. Okay, always divided up into conservative, medical, and surgical. So when someone asks you, how would you treat X, Y condition, you say, well, the treatment can be conservative, medical, or surgical. Conservative options include this, this, and this. Medical options include this, this, this drug. Surgical options may not be relevant in some medical conditions, obviously, but you can say, well, surgery tends not to be used for this condition. Okay. So that's the basic structure of a disease-centered approach. Let's talk very briefly about a patient-centered approach. And what I mean by this is when you get asked by consultant, oh, what's the differential diagnosis for a patient presenting with chest pain? You can't use the disease-centered approach really there. You can't really say, well, what's the definition of chest pain? What's the epidemiology? What's the, because there's so many causes of chest pain. But what you can do is talk about differential diagnosis. Okay, and this is the patient-centered. This is really about the patient-centered approach. So, when someone says, "What are the causes of chest pain?" is a bad example because you should really know all pretty much a sort of list of 10 causes of chest pain, pretty much off the top of your head without thinking about it. But if someone said, "Well, what's the cause of proximal myalgia?" for example, you should have a few common causes just available straight away, and those should be the most common things. So even though I'm very much against lists, and that's probably come across already, learning lists is a bad thing because you will remember them for the exam but never afterwards, and they won't be useful in your practice. For some conditions, some presentations of conditions, you need to know what the most common causes are, and you should just try and memorize those things. Once you start working, it becomes very easy because you see the actual conditions in association with the presentation, so you just memorize it because you've seen it. But at a student level, try and remember 2 or 3 common causes. Then what you need to do is take, again, a structured approach. Okay? So someone says, what are the causes of chest pain? Okay? This wouldn't be relevant here, but with some other things, it's very useful to start with a very broad base and say, well, causes of that can be either congenital or acquired. Okay? And then you could go on to say acquired causes are X, Y, and Z. Now, the system that we like to use is a sieve system, which is vitamin, okay? And we go through each stage and you say, well, vascular causes of chest pain might include, okay, acute coronary syndrome, which Steven's going to talk about, pericarditis, that kind of thing. Infective and inflammatory, okay? So chest pain could be caused by a pneumonia. Traumatic chest pain can be caused by a rib fracture. Autoimmune or allergic, well, I suppose maybe pericarditis might come under there. Metabolic, idiopathic, iatrogenic, maybe we cause the chest pain. Neoplastic, a lung tumor. You see what I mean? It's not a great example, but what it shows is that you need to have this structure to go through in your head. So know 2 or 3 common causes, and then go through this structure, or a similar sieve if you have one, and figure out what the rest of them are just from that. Okay. Right, so that's our first ditty. Are there any questions anyone wants to ask about those 2 systems? As I said, what I've just told you I think is the most important thing you're probably going to hear today in terms of how you go on in the future. Because if you use these systems and you get used to using them again and again and again, you will get better so much more quickly at medicine and at figuring these things out. Okay, so I'm going to hand over to Stevan now, who's going to do acute coronary syndrome.